Hello, everybody. Good afternoon. It's officially afternoon. Can everybody hear me? I'd like to welcome you to the Fairbanks Ethics Lecture Series. We've been doing this series monthly through the academic year for about 10 years now. My name is Paul Helft. I direct the Fairbanks Center for Medical Ethics. And it's a great pleasure. We have a super turnout today, and it'll be a great pleasure to hear this lecture by Jim Ryser, who gets the award for the most letters after his name. Just a few quick housekeeping items. A shameless plug. We host a year-long part-time fellowship in clinical ethics for anybody who might be interested. Many of our current and former fellows are here in the audience, and if anybody is interested in participating and learning ethics with us for a year, please come and talk to either myself or Dr. Alexi Torkey, who's the director of the fellowship. We'd be delighted to tell you what it's all about and see if it might fit with your life and career plans. There's an announcement about that fellowship at the front desks. So the lecture is being recorded and broadcasted today, and I believe we have guests from Ball, West, Arnett, and Blackford. And if you wouldn't mind turning off your cell phones, other devices, pagers, etc. Jim Ryser has no relevant conflicts of interest to disclose. So I wish I could share with you his entire biography because, among other things, he played and toured with John Cougar Mellencamp. Is anybody here old enough to remember when John Mellencamp was John Cougar?
Ooh, that's
okay,
cold.
Me too. He came to his current job of pain services at IU Health Methodist Hospital, as he says honestly. He had a successful music career as a solo artist and a guitarist and violinist with John Mellencamp in the 1990s. He graduated summa cum laude from Indiana University in 1999 with a BA in psychology and a minor in biology, and then went to John Carroll University in a master's program in counseling and human services. He did an internship at the Cleveland Clinic and then trained for pain rehabilitation at the Cleveland Clinic with Dr. Ed Covington, finished his addictions fellowship under Mike Denton and Dr. Fred Frick at IU Methodist Hospital. He currently works, among other things, with our Attorney General, Greg Zeller, as the chief advisor of the Attorney General's Prescriptions Drug Task Force. He's active with the DEA, helping to reduce so-called pill mills in the state of Indiana, and his pain rehabilitation program focuses on helping his patient population learn to manage pain without mood-altering medications with a focus on the 12 steps. So it's a great pleasure to welcome Jim to our ethics lecture today. Thank you.
Thanks. Thank you very much. Oh, do we have I need a little, this will work. Yeah, you know what they call people that fail medical school, right? Therapists. That's why I'm here. So those letters don't mean a whole lot other than I paid a lot of money to get certified to do what I do. I don't have anything to disclose, but that's what happens when you have pain and you do too much Demerol. You end up on stage in front of 70,000 people and wear a shirt that looks like that. So thank God those days are over. I think if we get the most important thing I'd like to see us get out of me being here today is looking less at the numeric pain scales and pain as the fifth vital sign and things of this nature that have been kind of forced upon us over function. What is it that we can do to help a person function better so that their pain becomes less of an issue in their lives? Promote self-managed care, and also very important to avoid iatrogenic relapse. So let's talk a little bit about disease. We've got lots of stigmatized diseases. I just finished a group for my patient population with chronic pain and chemical dependency a couple minutes before I got down here. And we talk a little bit about the stigma of disease. And there's lots of stigma with lots of different disease. STDs, people are afraid to tell their primary care physician their facts of their medical history. STDs is one of them. Look at obesity. We don't sometimes see that as an illness and something that can be medically stabilized. How about tobacco-assisted cardiovascular issues? People who smoke, there's a stigma against that. We see sometimes people who get the cardiovascular surgery and they're out on their break smoking cigarettes with their IV poles. I've seen people smoke through their stomas and their necks. I'm sure Dr. Weller's had to deal with that from time to time. We see these kinds of different things. HIV certainly is coming around. Addiction, as some of you may know, Obama just set aside almost $1 billion, $900 million for addictions treatment. We're in trouble in this country because of an opiate epidemic, and I have some opinions, and those are just that, opinions, on that during my talk. Iatrogenic relapse is an interesting one because we treat people for pain in an acute sense, and people with an opiate addiction, when they have acute pain treatment, which requires opioids, you're tickling those receptors. So how do we help these folks get their pain managed in an acute setting without relapsing? And one that has come up recently, we've got folks that have heroin addiction who are coming into the hospital needing cardiovascular surgery, needing valve replacements, and getting them into group and getting them compliant so that they can have an opportunity to have their lives. But, there's a stigma against that. I've spoken to people who say, I don't want to operate on those people, and I understand that thought process because, this is a social disease. This is a brain disease in a social context. So we'll talk a bit about that as well. Very, very briefly, does anybody know who that is in the picture? That is Eric Kandel, and he did some groundbreaking research on the Aplysia, which is a sea snail, that helped us understand nociception. A sea snail does not have a brain or a spinal cord, and yet if you poke it with a hot needle, it pulls away. So we know there's something going on with nociception, and nociception is associated with tissue damage. And then pain is the unpleasant experience of nociception. So what's a good example of some pain from nociception that somebody might see on a daily basis? Bone break in the ER. Thank you, Dr. Schuffelbarger. See? No, that's tissue damage. That's pain associated with that tissue damage, and the pain is the unpleasant experience associated with that. What about suffering? And this is really what I work with chronic non-cancer pain, because we can't do much for the pain with somebody with chronic non-cancer pain. So our job is to help with the suffering. And can you have pain without suffering? Give me an example of pain without suffering. Might be putting a picture up on a wall and hit your thumb. You know this is pain that's going to go away. You're likely going to go, ugh, and you might even say a choice word or two, but you're going to get on with your day, and later on in the day, you're not even going to notice it. What about suffering without pain? Where are my married people? Sorry. That's a joke. My wife's here too, and so I guess I know where I'll be sleeping tonight, suffering even more. No, suffering without pain, that's a death of a loved one. Severe depression. So all of these things interplay with each other when we're talking about pain. Now let's take a look at some addiction. Top picture, the picture before was Eric Kandel, who did this research on the Aplysia. Top picture here, I work with people with addiction every day, and a lot of people will say, well, I'm a functional alcoholic. Who's heard that before? Functional addict, functional alcoholic. And of course, my answer is everybody is functional with this disease if they have it, until they're not. Nobody ends up in my office by mistake. Very few people. As a matter of fact, I don't believe in my career I've ever met somebody on a winning streak show up to addictions treatment. It doesn't happen. So 12 to 15% of Americans have a lifetime prevalence for addiction, 30% of children of alcoholics, 35% of people with chronic pain who have been taking opioids for over a year, and 80% of heroin addicts began with a prescription. If you look on here, that's William Halsted. He was the founder of surgery, modern surgery. He had a severe cocaine addiction. Howard Hughes there in the middle, he had an opium issue, accomplished a lot of great things. And then Stephen King, who had a major polysubstance issue, and his family intervened on his behalf, and he's successfully sober today. He says, there's several books I don't remember writing. As a musician, I can sort of relate to that. So let's take a look at some similarities between chronic illness and chronic pain and chronic non-cancer pain. One of the things that we focus on here at Methodist in our program is really looking at chronic illness as what it is. It's a chronic illness which waxes and wanes in its progression, and it waxes and it wanes in its treatment, and compliance to helping that chronic illness is what we're looking for. So look at addiction, continued use despite adverse or threatening consequences. Isolation is a hallmark of the disease of addiction. Loss of control, preoccupation with a drug of choice, progression of that process, and tends to run in families. Now take a look at chronic pain. A lot of folks will say, my quality of life is basically couch to bathroom to bed to couch to bathroom to bed. That's a pretty adverse consequence of that behavior, isn't it? Isolation, people trade their relationships for their pain, for lack of a better way of saying it. There's a loss of control in the lifestyle that they've had. Most people will feel helpless and hopeless, and there's a very big preoccupation with pain. It's also runs in families as well. So what happened that got this opiate epidemic out of control? We're all aware of it. We're all trying to do what we can with it. So let's talk a little bit of history. I believe this was 1986 that the U.S. News did this, and doctors have the means at hand to relieve suffering of millions of Americans. Why aren't they doing it? Now remember, we talked about the difference between suffering and pain here. And Dr. Frick, who is my medical director and one of my mentors, had said to me several times, he says, in the Hippocratic Oath, it says we're to relieve suffering. Some pain we're not going to relieve. And it's a little bit of a different paradigm than something that we've gotten taught over the years. But part of why we got taught this is because we had this situation where people who were suffering greatly with end-of-life pain were not getting proper treatment. There was an article by Porter and Jick in 1986. And there was a paragraph that said, people who have cancer pain who get adequate amount of opioids have better function and better life. And that was extrapolated into a science that blew up in the opiate epidemic. And it's interesting to me how that happened over time. And who remembers Thomas Dolby? Seriously, only one of us? So I won't do the She Blinded Me with Science song. Okay, I got your back, brother. I always like when he goes, science. But anyway, what's the difference between research and practice? Research, we have perfect patients. We have around 6 months of RX, low to moderate doses, no additional controlled substances, and tightly controlled RX by experts. What's the real world, you guys? Come on, you guys know. You got comorbid substance use, psych illnesses, poorly explained pain, years of prescriptions with moderate to high doses, combined with benzodiazepines, soma sedatives, and stimulants, and loose supervision by non-experts in addiction. What always sort of stunned me was the thought process that we got taught 20, 25 years ago, in that there's no ceiling dose for opioids. We treat the pain. There's no judgment for that. But how many of us have walked into a patient's room and seen a person saying, I've got a pain at 10, but they're passed out in their Cheetos? Okay? So again, I'm challenging us to look at a different paradigm to focus on function with this. This was kind of interesting. Dr. Covington, with whom I trained at the Cleveland Clinic, they went over some pretty amazing data from one of the large insurers. And usually about 18 to 24 months, people with chronic non-cancer pain who are using opioids for that tend to stop using it because of loss of efficacy, or they're not happy with the side effects. Some of them develop constipation, they develop the lethargy and certain things. They're just not happy with the side effects. 30% will have about 30% pain reduction. A few will have sustained significant benefit, but they typically can't be identified in advance. We know for a fact what happens when addiction becomes part of this, and we'll talk a little bit about that. But it's interesting to me that, and Dr. Frick actually pointed this out, do you know how many double-blinded prospective research studies have been done on the efficacy of opioids for chronic non-cancer pain? Anybody want to take a guess? 0. So all of this science was based on a lot of data, pharmaceutical companies paying for research. There's a lot of that in there. And we live in the real world, so we'll talk about that as well. In practice, this is a Kaiser study, 4 million customers. Patient at highest risk receive the most drugs. And who is aware of the opiate tolerance level order set that's circulating through Indiana University Health now? This is something that we kind of noticed over time. Jill Payne and a whole group of folks really worked hard on this. This is, what happened for me as a consult person was I was seeing a lot of people who were getting opioids that probably ought not to be, and I was seeing people who really needed, at least in my opinion, opioid relief who weren't getting it. And we wanted to find a way to help stratify these folks so that they could get the best treatment and the best care without exacerbating addiction if that's possible. And that's how this kind of came up. But it's interesting that substance use disorder patients were getting higher dose regimens, more day supply. They were more likely to receive short-acting opioids and more than likely to have 180 days of sedative hypnotics, Valium, Soma, other drugs that potentiate the effect. And so it's just kind of interesting how that happened with people with opiate use disorder as well. So it's the old squeaky wheel gets the grease phenomenon. And that's with a practice of 4 million customers. So one of the things that we do in our chronic pain rehabilitation program here at Methodist, so are most of you familiar with our program here? Those of you who aren't, I'll tell you a little bit about it. One of the things that happened when I was training at the Cleveland Clinic is Dr. Covington said, I wish that everybody who had chronic non-cancer pain also had a substance use disorder, because it seems to me that most people who work a 12-step program recover better from both illnesses. And that kind of hit me, and I thought, well, why not see if we can't add the benefit of 12 steps to chronic non-cancer pain? Could this be something that somebody that does not have an addictive disease sink their teeth into? And so one of the things we looked at was, if you look at step 1, we admitted we were powerless over alcohol. This is the steps based on Alcoholics Anonymous, that our lives had become unmanageable. Well, a person with chronic pain really can grab a hold of that. Yes, I'm powerless over my chronic pain because I don't know how I'm going to feel on a day-to-day basis. And my life certainly is unmanageable because it seems like my whole life is being run by my pain. Who's run into people that feel that way? And who's worked with patients that will tell you this? So step 1 for chronic pain is actually a little bit easier for the person with chronic pain who does not have a comorbid addiction to get their hands around. What's interesting about it is as they begin that program, one of the things that happens is there's a fellowship involved, and so people start finding out they're not isolated or alone. How many people have you worked with who feel like they're the only people that have the pain that they have? And you've heard the thought process, if you knew how I'd feel, ... You don't know my pain, ... So I'll give you some kind of ideas on how to help that person so that they can come out of that and continue to recover. So right now, one of the biggest barriers we have is we live in a fix-me-now mindset. It's very shortcut. What's the quickest way to the end? Give me something for my pain so I can get on with my day. I've seen it so many times. It was interesting. One of the things that I've been blessed to be able to specialize in is helping nurses in recovery who develop an opiate use disorder over time. A lot of times where this comes from, some people are what we call crib addicts. They're out of the womb and they're addicted to whatever comes their way. And other people get it honestly, for lack of a better way of saying it, from environment. Some people get it honestly from genetics, and some people get it from environment. Find an extra Vicodin in your pocket, single mom dealing with kids at soccer practice, have a headache. Hey, I'll take this Vicodin and that'll buy me 3 more hours. And that's typically what we see. So that thought process of, I want to be fixed, I want it to be done, and I want to move on with my day is very ingrained with all kinds of disease. So in pain disease, that's a little bit different when we have chronic non-cancer pain, where the predictability of the quality of pain may change from a day-to-day basis. And then there's the other part. What are some other chronic behavioral illnesses that people can have? One that we often talk about in our program is diabetes. I would normally say who in here is diabetic if it was group, but I'm not going to do that. That's your business. But some people who will say, yes, I have diabetes, and sometimes I fool myself on my sugars, and I think, I'll just give myself a little extra insulin later and have this piece of cake. Now, I'm not a physician, but Dr. Schuffelbarger, is that good compliance to treating diabetes? It is not. Okay. So, and I trust Dr. Schuffelbarger's judgment on that. So, but we tend to forget that chronic illness does wax and wane. I was working with a medical student the other day that gave me one of the best examples I've heard about compliance. He was really close friends with a person who had cystic fibrosis. And this person sometimes just gets sick of all the things that he needs to do to treat his cystic fibrosis. The consequences of not following that compliance all the way through, well, he could potentially get a life-threatening infection and other consequences that come from that. But every once in a while, he'll say, I'm not in the mood to do the vest today. I want to hang out with my friends. And so it's a human thing. It's a human thing. So that's some compliance issues. And we will see the same thing with pain and addiction. There's an external locus of control versus internal locus of control in the patient population, which basically translates to this. I'm going to go see the doctor, and the doctor is going to fix me, and I'm going to be just fine. Where's the patient's part in this treatment? So part of our chronic illness recovery model is let's find what part you have and let's maximize that part so that we as your clinicians can certainly do our job, but we're also going to help you get better yourselves. I think I find that most in physical therapy in our chronic pain patients. We have several of our wonderful physical therapists here that come and help us out every morning. How happy are the patient population to do physical therapy every morning? Usually not happy at all, especially when it's Whitney, because she's really mean. How happy is everybody after they're done? Okay, now let's take a look at an addict mindset for a minute. What's the addict's immediate thought process? I want what I want when I want it, and I want it now, right? We all understand that. Most people don't think like that. Most people say, hey, I'm willing to take a little pain to get through this. I'm willing to do a little work to get on the other side of that. So that's where the importance of physical therapy is such a huge part of it. Getting that internal locus of control. Because from a unmanageability thought process, when somebody feels unmanageable about their drug of choice or whatever it is that they're using, or they're feeling unmanageable about their pain, that's pretty powerful. But giving somebody some control, so what we say is it's unmanageable, but not unmanaged. So we're starting to look at changing that and giving that patient some empowerment as a result of that. I put the real world of patient satisfaction on here because one of the issues that we struggle with, I was just on looked at a web server of HCAPs talking about the fact that treating pain is really not that big of a piece of the financial pie. But the reality is I know what world we live in, and so does everybody in this room. And that's something that we have to be aware of. I think I'm doing everything I possibly can with our legal eagles and CMS and as many people as I can talk to. We can be inadvertently hurting people with that patient satisfaction for pain. So my opinion is that some people are not going to be satisfied with any pain treatment that we give unless they're comatose, and they're not going to be satisfied with that either because now you've ruined their high. So again, my point is that we have to understand that we're not going to make everybody happy from the pain standpoint. And in my opinion, I don't think we should. We should be more aware of what's best for that patient's overall care. And sometimes adding pain medications and narcotic pain medications are actually more detrimental to that patient. And the other thing that we deal with, at least in our field, I always tell people, if I do my job right for the next 6 weeks, you'll fire me. You will not need our services. You will be able to go out in the community and gain the support that you need. Hopefully join a gym, take care of your chronic pain and your addiction. We work in a 12-step philosophy, so meetings are free or $1 or whatever. It's not expensive to treat this on an ongoing chronic basis. Sadly, in the world that we live in, it's very good business to have people come into your office and get medications. We see that with pain clinics. We've seen that with pill mills that got out of control with that philosophy. So I guess maybe I have a poor business model. I like to get fired. But I understand that other part of the world, and that's one of the things that we're facing as we continue looking at treatment options for chemical dependency as well as chronic pain. We've been in practice here for 13 and a half years. I have had one person finish the program who stayed on opioids because this person had a cancer that he was dealing with, but once he got his transplant, he no longer needed opioids. That doesn't mean that everybody who comes in has to be and should be opiate free. It's just we like to use opioids less as a first, second, or even third line of defense. There are so many other things that we can put in place. But on the acute pain side, remember what we talked about nociception. What is the best drug for nociceptive pain? Opioids. So we'll talk a little bit about how to deal with that. Here's some contributing environmental factors for both illnesses that we can kind of all get our hands on. Raw nerves, anxiety, turmoil, drama in families, drama in life, people who have a defeatist attitude, people who wait on them because of their pain, which is why we call chronic pain and chemical dependency a family illness. It was interesting, I saw some fMRI research where the sound of the person with chronic pain, the sound of their enabler's voice made their pain level go up. So, oh, honey, you're having a bad day. You want me to get you some Percocet? Mm-hmm. Okay. Now, is that feeding addiction or is that chronic pain? Could be both. And it's just kind of interesting to me. So again, we're looking at a complete family dynamic here. We're not looking at just the patient. We're looking at the family dynamics of this. Some other things that make these problems worse: living with someone who discourages physical exercise or encourages obesity, the use of drugs. We do have the occasional person who does prescribe just about everything. And then a lack of spiritual support. And that's one thing that we can't really measure. You know, we can measure some of the symptoms of addiction, if you will. What are some of the symptoms of addictive disease that we might see that are consequences that a person might have? Financial, right? If I'm selling my brother-in-law's power tools to get money for cocaine, that's a pretty significant problem, is it not? Right? We have relationship. What usually happens in relationships with chronic disease that's not treated. Quality of those relationships go down tremendously, if not sometimes even go away. We have occupational issues. If our love for a substance or our relationship with pain has gotten to a point where it affects our occupation, that's pretty impressive, isn't it? And the one we can't really measure so much is the spiritual part, but that's where we hear about isolation. People who truly feel utterly alone. So fellowship and getting together is such an important part of that. So let's talk a little bit about abstinence-based pain and addictions treatment with 12 steps. This is Bill Wilson and Robert Smith. Bill Wilson and Robert Smith were the co-founders of Alcoholics Anonymous. Robert Smith was a physician, and his last day of drinking, or his last using day, he had to do surgery, so they gave him one beer so he would stop shaking enough to where he could perform the surgery, and that was his last alcoholic beverage, and he stayed sober until he passed away. Bill Wilson was the other co-founder. And what these two gentlemen did is they had met, both of them were of the hopeless variety of alcoholic, and Bill Wilson was in an opportunity where he could either drink or do something different. He'd been through treatment 6 times through treatment, and was considered a failure by all that treated him. And he had a meeting with Bob Smith, and both of them decided to discuss things. One thing that they realized over the course of their 7-hour first meeting was that neither of them drank, but they related to each other in a way that nobody else ever had. And that was where this whole program began. So groups are wonderful in stifling what we call terminal uniqueness. Our physical therapists, when you see somebody for their first day with their chronic pain, I can't do physical therapy. I've tried that. And then Whitney goes, tough, get down here, come on. Because she knows that everybody getting together and working towards the same common goal gives something to hold on to. Suddenly you're not isolated anymore. So group support is huge. Then you also get an ability to unburden oneself, sharing triumphs and defeats. You need a supportive program that they can really grab a hold of. That's what I love about the exercise component of our program. It was interesting, you heard that I had trained with Mike Denton, who now works at Terra Treatment Center, and when he left, I had to do both chronic pain and chemical dependency programs, and I'm kind of one that kind of doesn't want to lose certain aspects of it, so I did everything I could to combine them. And so what ended up happening is we had people that had alcohol or drug issues that did not have pain issues, but they all participated in physical therapy. What do you think happened to those folks? They got better quicker. We actually did some data on this, and they got better quicker, probably because their exercise itself is just such an important part of getting people back to their function and they're getting their brains back to balance. That's the neuroscientist's job. I don't understand how that works, but the bottom line is that getting exercise is such a healthy part, and most people with chemical dependency lose that by the time they end up showing up in an inner city hospital for treatment of that disease. So we talked a little bit about what step one meant, powerless over the pain perception, but you're not powerless over what to do about it. And that's a big thing where groups are really, really helpful for. We all have heard about and read about folks that are doctor shopping for a cure, but I've seen several folks over the years, with neuropathic pain or pain that's not really going to be responding to anything scientifically that we know of as of right now. And a lot of times people will continue to go from doctor to doctor, really looking for something that's not there. And that becomes its own obsession, not unlike the person who's chemically coping and looking for more chemical, looking for that comfort. And so that's another situation where both populations tend to be able to come together. A lot of times early on in any kind of diagnosis for any new chronic fatal illness, what are the two hallmarks of those? Denial, right? Oh, Dr. Schuffelbarger just said I got terminal cancer. I'm going to go get me another opinion. Oh, shoot. Michelle said it too. Oh, daggone it. Linda said it too. Oh, shoot, I'm terminal. But if I keep denying the problem, how active am I going to be in the treatment? So getting rid of that denial and resistance to treatment, some people do have to come to terms with the fact that science hasn't developed yet to be able to deal with this particular type of pain. So we can help stop some of these obsessive behaviors. And that's a really big, powerful part about fellowship in 12 steps. That's not to say that we don't continue to look for some solution. It's finding a better balance with that. And learning a new lifestyle is absolutely key. And I put this on here. Moses Maimonides was a physician. He was also a Greek rabbi who practiced medicine 800 years ago. And Moses said, there is no medicine that can make up for lack of exercise. And I do believe he's still correct on that. I think it was Voltaire that said, if an illness can be taken care of by diet and exercise, let it be diet and exercise that takes care of that problem. So we talk about the numeric pain scale. I don't know if I'm compliant or not, but I never use it. It's not, first of all, pain's not a vital sign. My hope is that we begin to really continue to hammer away at that. I sent a letter to the medical director of Joint Commission asking, why are we still functioning in that? Pain is the fifth vital sign, and they sent me a response back saying that Joint Commission doesn't say that. So I'm going to hold them to that when they come and visit. I'm going to show them that letter. But here's the reality, and I've had the pleasure to work with so many great docs here and so many great clinicians and nurse practitioners and PAs that, when we're dealing with somebody in an acute pain who has a chronic pain issue, the question you want to ask that patient is, what's your typical pain on a typical day? Oh, about a 4. Okay, we're not going to get any lower than that while you're here. And if you're dealing with surgical pain, you're going to have some pain. So helping shape expectations is much better than saying, oh yeah, you're going to be fine when you come here. You're going to be great. You're going to get this surgery. You're going to be out walking, your knee replacement. Have you ever talked to somebody who's had a knee replacement? That's a painful surgery. So again, having that expectation set up for that patient to succeed, to me, is much better than saying, what's your pain on a 0 to 10 scale, and then trying to chase that. And if you'll notice, your function, what we're looking at is that function. What can we do as your nurses, doctors, to help you to where it's comfortable for you to get up? Yeah, you're going to hurt when you get up. You're going to hurt when you do your incentive spirometry. But what can we do that can help you be comfortable so that you can function, so we can get you home sooner? Notice my choice of words. I use the word we. We, as your team, as your nurse, as your doc, as your clinician, what can we do to help you get back home to your family where you want to be? And these are nice things to say. People really appreciate that. I've found that people appreciate more, hey, this is not going to be a real pleasant surgery. We're going to do our best to manage your pain, but you're going to have some. And people respond much better to that than, oh, you're going to be fine. Here's some more IV Dilaudid. Yes, we'll push it fast and add Benadryl. So, what's our part as chemical coddlers? Because we've gotten into this. Hey, let's just put the truth on the table. We want to help. If I have my way, every patient that comes into our program leaves there, never relapses, and has a great life. That would be my dream come true. That's not the way it's going to happen. I know that. But immediate help may exacerbate a past problem. So getting a good, accurate history is very important. Dr. Schuffelberger and I actually were speaking on behalf of IU up at the State House one day, and he said, it's interesting. If there were a 5% chance of developing a fatal complication based on adding a medication, I'm not so sure I would add that. And yet that was one of the things we talked about with the addition of hydrocodone. So we have to look out for that patient. We have to look out for that as well as prescribers, those of us who do. What I found interesting is opiate overdose deaths have tripled since 2001. That is beginning to level off with the prescription drug, but as we all know, the heroin epidemic has started as a result of, not as a result, but certainly has added to the problem. And then again, shifting of thought process for different pain types is a real big key. There's so much difference between acute pain, acute on chronic, end of life, chronic non-cancer, cancer, and palliative pain. I've always been one that if somebody's at their end of their life, whatever works. And that was where we started to begin with. Whatever works. Does not matter. Whatever's going to allow you to be able to hang out with your family and function to the best of your ability until you're done, that's wonderful. But some of those processes don't work for other types of pain. So being aware that pain is not just one entity. There's lots of different entities with that. This is kind of a neat little chart because it helps you understand the opiate misuse spectrum. If you look at the, I was going to say this side, your left, opioid naive patients have less interest in using opioids. People who haven't had opioids or are sparse. Since my wife is here, I'll pick on her. She had a surgery one time and they gave her some Vicodin. And she's never had Vicodin before. And she says, "Oh my goodness, these make me feel dizzy. I don't think I'll take them anymore." She doesn't really sound like that. We've been married long enough to where she sounds like this now. Just kidding. And people say, "Ryser, you deserve to suffer." There's no interest. But as time comes by, and let's say we use opioid therapy and that pain management happens, and we do get that, most people who are going to benefit from opioids for chronic non-cancer pain will have a ceiling level. You're not going to have this continued titration of opioids, and nor are you going to see a rapid titration. So now, if we start looking at that other side of the spectrum, when people may be using them for recreation, oh, shocker, sometimes people actually get opioid prescriptions and sell them. All right? That's one of the reasons why UDSs are very important. Yes, even the little old ladies in our practices. I had one that I was working with family practice one time, and she was so sweet and so pleasant. She was very compliant with getting her narcotics filled every month. Urine screen said there wasn't anything in there. She was selling them so she could supplement her income. Was that a bad person? No. This is a person who needed social services. So we were able to line her up with that and get her the help that she needed. And she didn't have to sell drugs anymore and feel horrible because that's what it took her to. So again, looking at this whole spectrum. And then, of course, then you start looking at diversion. People with addiction, and I think I'm not speaking out of school by saying this, will do anything to not feel with pain, not feel the pain of withdrawal. Opiate addiction is interesting in that most people, by the time they show up in our office, aren't getting high anymore. They're using just to feel normal. And they're doing everything they can to avoid the pain of withdrawal. Withdrawal is very painful. People will say it's like having a flu that is 100 times worse than the flu. And even that they'd rather have. So a lot of times when we're looking at recreation and diversion, sometimes this is just a survival mechanism, and that's kind of how we have to look at it. And despite the fact that there's criminal behavior involved with people, these aren't bad people trying to get good, they're sick people trying to get better. And that's an important quality to kind of remember as we as clinicians are working with folks who have an active disease. Because, gosh, how many times do you just want to smack somebody? Right? I know the nursing staff sometimes does. I know the nurse practitioners do, because it's like, gosh, don't you get this? Well, unfortunately, no. You cannot think. If you don't have an addictive mind, you can understand the addictive thought process, and that I want what I want when I want it applies without regard to consequence. This is an interesting phenomenon that Dr. Covington and I were talking about, and it's especially now, we have to be very careful with this because we have different types of treatment. There is opiate replacement therapy available in the form of methadone and Suboxone, and I'm not paid by any pharmaceutical company, so I just want you to know that. But so what do you do if somebody is on an opioid replacement therapy and they have an acute injury? So these are challenges that we have to be aware of. Or somebody who's sober who comes in the hospital and says, I'm getting ready to have surgery, but I've been sober off opioids for 10 years and I don't want anything. And you realize they're going to be having maybe they might be having a cabbage. And so we know that's very painful. So both ends of the spectrum we have to be very careful with regard to relapse. And the reality is, yes, we should treat pain, even those with active opiate addiction. Absolutely. There are ways to do it, though, to do the best we can to minimize the exacerbation of the addictive behaviors and disease. What's the worst drug that you want to give somebody who has an active addiction? The short-acting version of it. The shorter acting, the more rewarding, the more difficult it is to stop. So the longer-acting drugs are actually more indicated in a situation like that. We'll talk more about that in a minute. And of course, we've already talked about opioids are best indicated for acute nociceptive pain. A lot of clinicians worry about whether or not they cause addiction, and oftentimes in an acute setting, very, very rare. Rarely are we worried about relapse, and we should be. Because I can't tell you how many times I've had somebody come back into the program who'd been sober, going to meetings, doing what it is they're doing in an abstinence base, who went and got a root canal, got 60 Vicodin, and the next thing you know, 5 years later, they're back in treatment. How did this happen? 60 Vicodin didn't help. So Dr. Frick and I came up with this thing, and I've got copies of it in my office. This should be a state form over the next year. We all know how slow things go in big government, so we just have to be patient. But this is an advanced directive for the prevention of iatrogenic relapse. And this is a patient, it's like a post, patient says, here, this is my drug of choice. This is who my sponsor is. This is who is my treatment provider. Dr. Shufflebarger is the only person that's going to write for me. I only get filled at CVS. Here's my Dr. Shufflebarger will do the inspect report. But the point is that this is getting involved in your care. How many people notice in any chronic illness that the more involved a person is in their own recovery, the better compliant they are and the better their outcomes are? So addiction and pain are no different. And so this is a nice form that all of our patients get, and I've had very nice success with folks who come in and say, hey, I'm getting ready to have a minor surgery. I just want to make sure I don't get myself into trouble again. People with alcohol use disorder tend to relapse on opioids less than somebody who has an opiate use disorder. That makes complete sense. We would see people with an alcohol use disorder having relapse issues more with benzodiazepine, which works on the same receptors that alcohol does. So what do? We treat the pain. We watch for observed intoxication and refer as needed. If they are on chronic opioids to begin with, those are considered baseline, and then we might use an additional short-acting. This is for acute pain, by the way, in the chronic pain or the person with opiate addiction. For breakthrough pain, opioid rotation, and we have to know our own reaction. I've worked with staff. I've been fortunate to be able to help staff who struggle with, knowing that they may be potentially feeding somebody's addiction and how to manage that. What is our own reaction to that? We have to know that so that we can be of best benefit and not wear that home. I can remember the first time I lost a patient on my watch. 22-year-old kid just getting ready to graduate law school, developed a heroin addiction just at a party, had a couple of oxys, ended up on heroin, and he overdosed on my watch. And I thought I failed this kid. No, I didn't. No, I didn't. The reality is this disease got him. It's no different than any other chronic disease where people die from it. And conversely, people's success do not depend on me either. And I make that very clear with my patients. What's going to depend on your success is what you put into it. Remember, internal locus of control. What you put into it is what you're going to get out of it. And yes, I'm part of that team, and I'm going to help you. But if you don't put the work in, you don't expect to get better. And the other clinician challenge, my nurse practitioner always gets frustrated when somebody comes in and says, what are you going to do for my pain? Of course, Susan has the luxury, because we are chronic non-cancer pain, of saying, not much. You're going to be doing the work. Now, in an acute pain setting, very different. End-of-life pain setting, very different. So you see where we're at with that. But again, being able to stratify these different pain types will help us in helping that patient with that pain. This is what not to do. Send them off with a 30-day supply and a letter of discharge. I've seen that so many times. I smoked some pot and they kicked me out of the practice. Well, I'm okay with that, but did you get a referral? Did you get a wean? Were you able to get substance abuse treatment options? Well, I'm here now. What are you going to do for me? Oh, shoot, here we go again. So again, we don't want to do that. We don't want to use short-acting opioids for weaning. It's better for an opiate addict. We want to use a long-acting opioid. Certainly don't trust the addicted person to wean themselves. I've seen that several times over the course of the last 15 years where, my doc said, here, do this. He said, take a couple less each day until you're done. And there is some naivete with that because, again, addiction is a complex biological disease. And so, again, expecting an addict to wean themselves would be like expecting everybody in this room to hold your breath for 5 minutes. It's not going to happen. It's not going to happen. So, and then assume any patient will disclose an addiction diagnosis. I do my very best with our patient population to help educate them. Listen, you tell your doctor the truth about your alcoholism or your addiction because that's going to save you in the long run. There are no more free ones. So some conclusions. Opioids are quite helpful for many patients with chronic non-cancer pain. They are useless or harmful for many, and it is difficult to predict benefit or harm. And harm to society is substantial and increases with the use of higher doses. Most societal harm occurs with people who never had a prescription. So again, those of you who have a prescription, make sure you lock them up. People check your cabinets. I had one that said, I used to go on go check houses for sale, and then I'd go, can I use your restroom? And then get some stuff out of their cabinets. What always impresses me is a lot of times people say, really? People would do that? You betcha. I've heard it all, and nothing surprises me anymore. Nothing surprises me anymore. You can invent the most crazy thing in your head about what somebody will do to get a drug of choice, and it will have happened somewhere in this country, is what it is. With meticulous prescribing, those who benefit from opioids should and can get them safely, and those who do not can be protected from them. And it's unclear the extent to which physicians and clinicians who can prescribe can adequately benefit society. My opinion is this, and I've always thought this in our program, both in chronic pain and with chemical dependency. Benjamin Franklin said, nothing is more fatal to health than an overcare of it. And we see this a lot with our chronic pain folks who are just on this mission to try to get something that's not ever going to happen. I'm a big fan of taking care of yourself, but I'm also a big fan of living your life while you're doing it. And so that's kind of a message that we try to get across with folks. So I want to give you an opportunity to ask any questions. This is a picture I took when I went out to Pennsylvania last year. Isn't that cool? It was like, I waited 5 years for that picture. This eagle would never show up in the tree, and then I literally just drive up to my little vacation site, and there he is. I'm like, shoot, all my cameras are packed in the trunk, and I'm thinking he's going to fly off as soon as I get set up. And I got that shot, and then away he went. So some fun stuff. Do you have any questions? Any comments? Yes?
You have a microphone for the sake of people.
Oh, that's right. Okay.
We seem to be seeing a lot more Suboxone. Could you talk about that just a little bit?
Sure. You got to understand, I'm a biased clinician. Dr. Frick and I have a biased program. So we are not fans of that for various reasons. The reason that I'm not a fan of it being long-term with no treatment. So, and that is a danger that we face, people just getting thrown on Suboxone and then no follow-up. To me, it's putting a Band-Aid on an infected wound. Now, there are people who are using it properly. I do know several docs that are, they demand that the patient goes to treatment and continues treatment. But I think that the thought process, and I'm going to quote my medical director on this, the thought process of Suboxone being the save-all for this opiate epidemic is as much of a fool's paradise as the chronic pain epidemic that started this whole thing. It's just my opinion. Donna.
I'm a pharmacist, and I've had the opportunity to do some travel in Europe with some other friends of mine. We go into the pharmacies there, and in multiple countries, opiates are not kept in any retail pharmacy. The thing is, if it's really severe, you go to a hospital pharmacy. There seems to be a totally different approach to chronic pain in Europe. Have you seen that, and is that the way that we need to be pushing more? I think it has to do more with functionality and telling patients they really... You don't get it.
I would like to see that, but it's not going to happen. There's too much money in it. It's just the way that it is. And sadly, this isn't something that the doctors caused or the pharmacist caused. This is something we caused. This is a societal thing. Americans demanded pain relief. Americans got pain relief. Some people got addicted. They began demanding more. We miss, with the pain end of things. I remember going to a conference in 2001 in New York City. Was a chronic pain and chemical dependency conference. And I'm like, oh gosh, that's awesome. They're finally getting their hands on the fact that opioids are causing more problems than they're solving. And nothing was further from the truth. These were specialists who were touting the benefit of high-dose opioids. 3,000 milligrams of morphine equivalent a day is perfectly fine and acceptable. I mean, it's frankly insane from my own perspective. And so I said, well, there's a big train coming around the corner. And I offered my opinion, and it just wasn't there at that time. Does that mean that everybody has to be abstinent? I don't believe that either. I think there's a balance there. The problem is just like I said, we don't know who fits that balance. There are certain things that you can test for. You can test for family history of addiction. They've got the SOAP. They've got several different things that are valid tests to know who stratifies in a possible abuse or use situation. But I agree, we over-medicate pain. Chronic pain wasn't even an issue until Purdue Pharma bought the oxycodone molecule in 1962. So, but, we know how marketing is. Shoot, halitosis wasn't invented until somebody said, hey, let's invent bad breath so we can sell this Listerine that's useless on the shelf.
Hey, Jim. Early on, you talked about the difference between those you were evaluating people who shouldn't be on any opioid pain meds treatment, but then you came across patients who did need to be on that kind of therapy. Can you describe that kind of patient that you saw that actually needed to be on opioid therapy?
What I shouldn't say is need versus not need. What I should say is who will likely benefit versus not benefit. The person who's taking 2 Vicodin a day and has been for the last 5 years is a patient I will never see because they're compliant. They're not causing any trouble. They're showing up to their appointments. Generally, you're not going to see a lot of adverse effects with that because, again, it's dose. There is some dose-specific cutoffs, if you will. One of the things that the Opiate Use Task Force or the Prescription Drug Use Task Force we're discussing is where is that cutoff? The Physicians for Responsible Opioid Prescribing say 120 milligrams. If they're not benefiting from 120 milligrams of morphine equivalent a day, they're likely not going to benefit at all. Here in Indiana, that's actually a bit lower of a standard based on data that where we began to see consequences with opioid use. So the higher doses is where we're saying we're probably not benefiting from opioids, and so we should probably try something else. Unfortunately, if addictive disease is part of that process now, and you've got the confusion of chronic pain or pain disease, what we end up seeing is a real reluctance for people to get off opioids. But the good news is we've got enough evidence on opioid-induced hyperalgesia to where we can help assure these folks that they're going to feel better over time. That's where exercise is huge, because when people start exercising and start feeling better, and they feel better quicker, and then suddenly their pain is not bothering them like it used to be. Does that help? Does that? Okay.
Do you know of any evidence to support the use of opioid contracts as far as are they effective in preventing addiction?
Oh, I don't think anything's effective in preventing addiction. Sadly in this country, we have a genetic predisposition and we also have the environment. You're never going to see an African bushman alcoholic. You know why? There ain't no alcohol in the African bush. The nearest bar is 800 miles away and you got to get there on feet. So you have to have the environment and you have to have the genetic predisposition. A contract, is that going to, agreement? If it's honored, I know lots of contracts that don't, oh, well, yeah, it's just a little pot. Okay, well, now that's a risky behavior. Are we sure we're missing that? Are we missing, or just not having one at all? I have not seen any evidence where those are useful. Dr. Schuffelbacher, have you? No. But I still see them, and frankly, in my opinion, from the addiction standpoint, the more accountability a person has, the better off they're going to be at managing that disease. Yes?
Do any of the methadone or Suboxone clinics have any sort of weaning process?
Just get right to...
Do any of those Suboxone clinics or methadone clinics have any sort of weaning process to them?
Some do, yeah, and some go slow. There are for-profit things, and I get that. But yes, some people will say, you know what, I think I want a different lifestyle. I'd like to get off of this, and they will eventually wean. Suboxone is notoriously difficult to get off of, and I don't know what the science behind that. Dr. Frick would be better versed at talking about that. But I've talked to people who've weaned off of Suboxone and weaned off of heroin. They said they'd rather go through heroin detox any day of the week. And that's another reason I'm not a real fan of that drug.
I just wanted to ask, I know the form that you said is in your office, the relapse prevention form that you have people sign, is that something that's going to eventually be able to be accessed for like an actual IU Health form, like on the forms page? I feel like that would be a really good form.
You know what? That's not a bad idea. I hadn't even thought about that because we talked about making it a state form, but yeah, I don't see any reason why we can't make that an IU form.
I just feel like for patients who have a history of that, it might be something good for any patient that goes through a surgery or a major procedure to fill out.
I'll find out who I need to talk to about that today. And if anybody knows, fire me a note, Ryser at iuhealth.org. That's a great idea. Thank you.
What is the best treatment for an OB patient who's addicted?
For an OB patient who's addicted, the standard of care right now with neonatal abstinence syndrome is to maintain that person on an opioid during the pregnancy and then deal with the neonatal abstinence as it happens. Some babies withdraw very difficult, some don't. But my opinion would be to do our best to provide treatment. At least at Methodist, we do have the luxury of allowing people to come into treatment. I mean, we're working with the cardiovascular team right now that if people are coming in and getting heart valve replacements, going to therapy and going to group is going to be a strongly suggested requirement. We can't demand anything. I get that, but let's do what we can to help treat that disease while we've got a captive audience. And so we see a lot of folks who are pregnant who will come to groups every day and give them the best treatment we can. Doesn't guarantee lifelong sobriety, but at least it gives them an opportunity to. Because the biggest problem that we've got is I don't think heroin's FDA approved. Floor shavings aren't a part of usual medication. So, we want to get them as safe as we possibly can get them. You see what I'm saying? So a lot of times people say, well, why would you maintain them? We used to wean pregnant women, but there are many complications that would come as a result of that. So we don't wean anymore. So. I'd like to thank you very much. Oh, thank you so much. I appreciate it.